I think next on the block is PI3 kinase. We know up to 50% of our patients at some point with ER-positive breast cancer will have mutations in PI3 kinase. An alpha-specific inhibitor, alpelisib, has the greatest promise of any of the PI3 kinase inhibitor drugs that we've so far studied, including the pan-PI3 kinase inhibitors, which either were not very effective or too toxic, and the beta-sparing PI3 kinase inhibitor, tacelisib, which had very minimal activity and a lot of toxicity. Alpelisib has the skin rash and hyperglycemia as well as weight loss that we've seen with the more focused PI3 kinase inhibitors, but it doesn't have some of the other toxicities like colitis, which makes it tough, and psychiatric issues and liver function test abnormalities. We've seen a lot of toxicities. Alpelisib doesn't really have those, but a press release suggested that in Solar 1, a randomized trial in patients in the second-line setting who received fulvestrant and placebo or alpelisib, that the primary endpoint of improved progression-free survival was met. We need to see those data that will be presented at ESMO later this October, but I'm very excited that this data will lead to the first approved PI3 kinase inhibitor in treating PI3 kinase mutant metastatic breast cancer. And obviously, maybe that'll lead us in the future to try and really understand how we're going to use targeted agents. If your cancer has a PI3 kinase mutation, maybe you should get that drug before a CDK4/6 inhibitor, and we're going to be learning that. And maybe we'll learn that in the setting of further studies with oral selective estrogen receptor downregulators, the oral SERDs that are where there's many, many drugs in clinical trials.